Good day, and thank you for joining. I am Sherilyn Francis, and on behalf of the Morehouse Healthcare Telemedicine Program, we welcome you to Part 5 of our telemedicine webinar series. Additionally, we invite you to connect with us. The URL for our website can be found in the lower right corner of your screen. The mission of the Morehouse Healthcare Telemedicine Program is to advance health equity amongst minority and underserved communities by integrating healthcare technology and advancements. I now present to you today's webinar entitled Delivering Virtual Care to High-Risk OB-GYN Populations, presented by Dr. Tanya Mack and Dr. Dorothy Mitchell-Leaf. In compliance with ACCME guidelines, the following presenters have no relationship with the manufacturer of any commercial service discussed in this educational activity. The Morehouse School of Medicine is accredited by the Accreditation Council of Continuing Medical Education to provide continuing medical education for physicians. The Morehouse School of Medicine designates this live activity for a maximum of 1 AMA PRA Category 1 credit. The objectives for today's webinar are to evaluate high-risk pregnancy trends among vulnerable populations, to critique the impact of social determinants of health on pregnancy outcomes, and to evaluate evidence-based practices to improve health outcomes among high-risk OB-GYN populations. And now, Ms. Mack.
Good afternoon, everyone. Hello, everyone. My name is Tanya Mack. I'm president of Women's Telehealth. I'll just clarify for everyone's benefit. Not a physician, experienced business person, though. Thank you so much for joining us. So my part of the presentation is to talk a little bit about telehealth, telemedicine, and just to give you a background, Women's Telehealth is based in Atlanta, Georgia. We are 100% maternal fetal medicine providers by telehealth. And we've completed in our past 8 years in business about 31,000 high-risk OB encounters in a variety of healthcare settings. We work in government clinics such as the county health departments. We also work in private OB practices, and we also work in second-tier and large hospital systems that do not have their own MFM. So that's the basis of what I'll be presenting today and where the experience comes from. When Mr. Gooden asked me to speak with you this afternoon, I took a good look at marginalized populations and looked at what our experience has been in terms of what kind of people we're talking about are the underserved across the nation. We have a lot of commonalities. We're talking about women and children, those in poverty. I'll kind of go into that in a little more detail in a minute. But I wanted to first talk about what issues we have seen in our experience across 31,000 high-risk MFM patients across lots of different areas, both urban and rural. In our business, 50% is urban, 50% is rural, which may surprise you. So I've got on your screen a list of issues affecting high-risk OB care in marginalized populations. And of course, the first one that comes to my mind is access to OB care. So we're based in Georgia, but we're licensed to provide telemedicine MFM services in the 7 Southeast states. So we have experience in that area. We've also looked at opportunities in the Southwest, the Northwest, the Northeast, and the Midwest. So I think we have a pretty broad perspective. In general, we find geographic coverage or availability of care one of the top things that we see. In a lot of states, there are 1 or 2 major cities, and if you're a high-risk pregnant woman not in one of those cities, you may have limited access to care. There's also very basic things in terms of access. We often find that our patients don't have gas to go to the other side of the county, so transportation is an issue. Sometimes once high-risk patients are identified, they are transported, or there are programs we run into where transportation is provided just because it's better to get them in and get early intervention than end up with a NICU stay later. So transportation is something that we see and hear a lot about. Language barriers. So here in Georgia and in the Southeast, like in California, we have bread baskets of America, like in the Midwest, where we have large migrant population workers. We have various pockets of people where we are seeing high-risk patients that do not speak English. So dealing with interpreters or bringing an interpreter, getting access to OB care that's understandable is another key problem barrier in terms of issues on the access area. Certainly everywhere in America, you can't pick up a paper without seeing healthcare insurance and where is it going and where are we now and what are the problems with that. So healthcare insurance coverage, as far as accessing healthcare, especially for populations that do not have health insurance, is a challenge. And then most recently, legal status. They're getting kind of sneaky about this. I was in South Georgia 2 weeks ago. One of the things I heard was that there was an ad in the paper for Walmart for shoes for $1. And everyone that came in was asked for their paperwork at Walmart, and they were carted off by ICE. So legal status and immigration and getting access to care for the women that are here, we're finding these and more. So my number one issue is access to care. Second thing, we're all feeling OB provider shortage. So in general, no surprise that we are heading into a period where we have retiring doctors. We have not too much need, not enough to fill it. In rural areas, I think it's worse. I know there's a lot of incentives to subsidize and get physicians and mid-level providers back into rural areas, but in obstetrics in particular, as in other specialties, just having enough providers to care for the populations, even if there was access, would be the second most common problem that I see. We visit a lot of hospital systems. One of the most disturbing things that we see is across America, and especially here in the Southeast, which is my backyard, we continue to have hospital closings of small critical access hospitals. I put in the slide just as an example. Here in Georgia, only 50% of our hospitals here in Georgia have labor and delivery facilities, and we continue to unfortunately have closings. So that just shoves the patients further away, more transportation problems. That's kind of unfortunate a reality where we are. And then what we're finding is a large disparity in maternal and infant mortality rates. So I'll be speaking a little bit more about maternal mortality rates. My latest frame of reference as far as data here in Georgia, we have a maternal mortality review committee, and they just published their findings, so I'll kind of go more into that. Women's Telehealth was also invited in December of last year to attend a federal policy making consortium of 90 invited guests to Washington, D.C. to talk about what we believe is now a maternity crisis in the United States. So unfortunately, we pay a lot of money for health care, and in the regards of high-risk OB and the outcomes, we are getting very poor results. So I'm going to move on to the next slide and talk a little bit about the populations that we see and kind of what's happening in them. So certainly what high-risk OB populations are affected or marginalized communities. Women and children, certainly we have. And for us, we take care of in high-risk OB up to delivery, and then the neonatologists take over, the pediatricians take over. We do see a lot of rural and migrant farm workers. We, I think, default on our minds a lot to telehealth equals more rural than urban, but in our reality over many years in a lot of different settings, like I said earlier, we are 50-50 urban patients and rural patients. So it's kind of everywhere. I think it's pervasive. Women in poverty, I'll talk a little bit more about statistics, certainly a high-risk population, and substance abuse. So these are the most common ones we see in high-risk OB care. I want to talk a little bit about impact by the numbers. So we talked a little bit about what we see in the populations we're serving, but I did pull together just some statistics to talk about when there is no access, what are these issues resulting in? So resource I put at the bottom and referenced earlier from the Department of Community Health here in Georgia, we have funded a maternal mortality review committee that provides data every year for the prior year's close of data. So they published their most recent results about a month or two ago in August, and these were some of the findings that I thought were noteworthy. First off, 60% of maternal deaths are preventable in Georgia. I don't have a national statistic. 49% Black, 12% Hispanic, 12% other, the rest Caucasian. We're just not getting early care. And here is a hard result of seeing what happens when we don't get early care. I said earlier, 50% of Georgia's hospitals have L&D. When I look at other states, they're similar. And so if I would look at like Mississippi, we have Jackson, Mississippi. We have a little bit in south down near the coast, not a lot in between. We're in Alabama, same. It can be repeated over and over and over again in states across the United States. Closures of critical care access hospitals are affecting every state. 50% of the deliveries in rural Georgia are paid for by Medicaid. Again, I don't have access to every state. You can probably look up your own, but getting services out everywhere is probably the key. I wanted to bring up just a couple of interesting things, not from the DPH report, but from our own database of this 31,000 visits over the past 8 years. 45% of our patients, the pregnant woman, as you know, and I'm sure Dr. Mitchell-Leaf will go into some of the clinical specifics of that. But we have diabetes type 2. We have chronic heart disease. It is not just it is delivery issues. It is imaging issues. So there is really quite a lot to manage. It was kind of shocking. I do a lot of speaking, and a 45% number is really high across multiple states. So that's, I think, a very alarming thing that we're dealing with in high-risk populations. We keep statistics here at Women's Telehealth too. Look annually at our production and our utilization and what kinds of diagnosis are we seeing and what kinds of studies are we doing to manage those diagnoses and what kind of continuity of care are we doing. And one of the most surprising things that we are finding is for the first time in 2018, when we look at our top 10 maternal fetal diagnosis, we have opioid use. So typically our typical is multiples, chronic hypertension, preeclampsia, birth defects, chromosome abnormalities, those kind of things. We have dealt with opioid use in the past, but not to this degree. So it is going up. We see it frequently. It is a big challenge. And I would say of the patient looking at the zip codes and the geographical areas where it is worse, it is typically worse in rural than urban is our finding. So this impact by the number was my attempt to just show you from a number of different perspectives that the U.S. has one of the highest maternal mortality rates of any industrialized nation, and we're one of the top 5 in terms of costs. So we are not getting the outcomes for what we're spending. Then I wanted to I'm going to go back. I wanted to talk a little bit about, I'm going to skip a slide and actually bring to light, okay, we've talked about the problems, but I also want to talk about a success story so we're not just frustrated out there, but you can see some very positive things being done. So I wanted to speak about a case study that was published by the American Telemedicine Association, in which a telemedicine partner, Women's Telehealth is the providers, and the state of Georgia Department of Public Health, all 3 entities partnered together. If you don't know it, I looked at the participant list. I know many of you are from not in our area, but unfortunately, Georgia and the Deep South are very low in terms of high-risk OB outcomes. So we are 50 out of 50 for maternal death, and we are 40-something out of 50 for infant mortality as well. So about 6 or 7 years ago, the then commissioner of the DPH here said we have to try to do something new, let's be innovative. And we partnered with the highest targeted statistics in the state, which our main metric was preterm labor rates as an indicator of what might end up being a NICU cost, expense, or terrible outcome. And we targeted Albany, Georgia, was our area where we had about an 18.8 preterm labor rate. So not good as far as the trend of babies heading into the NICUs and moms delivering early. We ended up partnering to create a centering pregnancy program high-risk component. So Centering Pregnancy is a group where once a month, a group of 10 to 12 come. They do get their antepartum chats, but they also stay, and then they have an educational component. And we partnered to come in by telehealth to educate about high-risk signs and symptoms, policies, things we wanted them to report, where they were in the pregnancy, and how they related to risk and outcomes. So they would get educated about what to report and compliance and keeping with their visits. We partnered this with telemedicine. So we put in a link to the health department, and if the patient was there for an regular antepartum visit, and then they fell out of the criteria of normal, they were referred for an MFM high-risk visit by telemedicine while they were there. And we then did image transfer. We did an ultrasound. We did image transfer. We could see everything by telemedicine, and we did an AV call with the patient, and they started down a monitoring track. The results were kind of astounding. I put in here in a nutshell, we were able over 500 pregnancies in the first 18 months to drop the preterm labor rate from about 18.8% to about 8.8%. The national average is about 11.5%. So below the national average and almost in half from where we started. That program still exists today. You can find this on the American Telemedicine Association in its full form, but it is one example of how a lot of stakeholders can come together to get concrete results pretty quickly. And so then I wanted to, I went backwards, sorry about that. I wanted to go through just some short and long-term ideas and approaches for improvement going forward. Certainly education is key. And in looking at education, not just for these high-risk moms, which we need to encourage them with, I think the two most important things, early pregnancy care, so we don't have critical problems right at the end when the resources may be the least, and also reportable signs and symptoms. We have a lot of teen moms, we have a lot of first-time moms, they don't know what to report, and unfortunately, sometimes they don't, and then we have a problem or a loss when we find out about it. On the providers too, side education about what appropriate meds can be used in pregnancy. Is there anything new in the literature as far as managing pregnancy in a high-risk population? MFM referral. OBs receive a lot of different training. Some are more comfortable with complicated situations than others. Some don't have resources in where they are than others, so appropriate MFM referral is critical. And then having a clear transport path, and everyone knows what that is when the patient needs to be transported to another facility. So certainly education is something that any provider can do where they are, any nurse can do where they are, any hospital triage person can do. So always take an opportunity to educate the patient in the surrounding area. I want to point out too, there are some government initiatives that I think are starting to work and be funded. So as an example, here in Georgia, effective in January of this year, we have a hemorrhage bundle initiative designation. And what that means is there was about $2 million set aside by the government here in Georgia to beef up the understanding and how to interact with antepartum and pregnancy hemorrhage, so people know what to do at the right time at the right place. And hospitals can apply for this designation and get educated and kind of go through the process. Here in Georgia also, just as an example, I know all the different states and areas are different, we have rural stabilization grants. So in telemedicine, a very good thing has been from the 8 years ago when I started and to set up both the host and the distal end in telemedicine, it was quite expensive. It's probably in the neighborhood of $35,000 to $50,000 to get the right ultrasound, get the right hardware, get a network, get the software, transfer the images, and get all of that done. Critical access hospitals, quite honestly, a lot of them can't afford that. Doctors' offices that serve very large rural areas can't afford that. Good news, it's come down. And so now with laptops, with widgets, with apps, with all kinds of Bluetooth peripheral, we're in a very affordable spot to put in telemedicine. Sometimes in even MFM specialty, it can be in the neighborhood of $6,000 to $10,000. So your ROI is really good. But even if that is a barrier, a lot of governments are supporting buying the equipment and outfitting areas that have a need, and then the providers can learn how to use the equipment. So here in Georgia, we had a program where we first had 2 rural hospitals apply for stabilization grants in a wide rural area where those funds could be used for outfitting telemedicine in different programs, and then it would be put up for use. That was then expanded to 5 hospitals, now 19 hospitals. So it's been a very successful model here. And then I would just say, you know, there are, as Dr. Mitchell-Leaf is one of those rare super subspecialists herself, there's just not enough of these high-risk pregnancy providers for the need. So how do we spread out their availability without brick and mortar? Telemedicine is now far enough down the track that it is proven, it's there. There are barriers state to state with reimbursement, with licensure, those kind of things, but many have been removed. So getting increased MFM coverage through telehealth is a cheaper, easier possibility than it ever has been. Longer term initiatives, and then I'll finish up, are certainly we need help with reimbursement. So every state in the United States still does not cover telemedicine to the degree of all specialties, and a lot of them will cover 2 or 3 specialties more traditional to telemedicine, like stroke or dermatology or behavioral health, but not on the list is high-risk pregnancy management or maternal fetal services or NICU services or pediatric services. So reimbursement for this particular specialty that we're talking about today is still a challenge in many areas, and there's probably 200 or 300 pieces of legislation across the United States, but it is all over the board. It is not standardized. That is still a problem. Mid-level provider expansion. Since we don't have OBs, we do have midwives. We do have nurse practitioners and people that can handle antepartum care. So expanding what they can do, the service cover area, that will all help. And then I think one of the biggest outcomes that I had from the Washington, D.C. policymaker meeting was that 4 out of 5 pregnancy-related doctors' costs are paid to hospitals. But the patient has 8 months of care before they ever get to the hospital, and we have a disparity in who's getting the money compared to where the need is. So I think at the federal level, we will continue to see some work done on bundling and continuity of care and what is the most appropriate care for what that particular patient requires, and expanded use of birthing centers and expanded use of that kind of thing. So I just wanted to kind of put out there some ideas and approaches for improvement that we see here in Georgia, that we see nationally, and that I know people are talking about. And that is the end of my presentation. So appreciate it, and I'll take questions in a bit.
Thank you. Dr. Mitchell-Leaf, you're up next.
Okay. Everything Tanya has said, especially about the problem with deliveries and obstetrics, is obviously tantamount to well, I'm going to go through my slides. It's really to talk about options for different parts of OB-GYN, and I know Tanya covered much of this information for the high-risk patient that obviously is the most important right now in reaching the patients out there in the state and elsewhere that need our help. Just general concepts: reaching a patient who doesn't need care but are unavailable to travel or have no doctors in their near vicinity is obviously essential. Providing needed care in areas that are underserved by general care physicians or specialists is absolutely the top of why telemedicine is necessary and helpful for patients here in the state. Patients that can't leave work or who have no transportation for care are also individuals that we have to think about. It minimizes, obviously, the time. Even if they're able to do so, their care is optimal via consultation over the internet rather than having to try and travel to see physicians. and concern for all specialties to reach patients in greatest need for medical services. There are 87 counties in the state of Georgia without OB care. That is half, as Tanya said. There are great concerns regarding the data regarding maternal mortality in the state, that we are the worst in the country. And having access to care through telemedicine provides that needed assistance to do ultrasonography to define issues during a pregnancy and appropriate follow-up and referrals as needed. And support care with physicians' assistants, extenders can help facilitate consults performed with the telemedicine for the patients. Obviously, Tanya could probably talk better about this, also about the ultrasounds and how they are able to be performed in certain areas by a certified sonographer that needs to be in the registry of diagnostic ultrasounds, along with a maternal fetal medicine specialist for diagnostic studies needed for the patients in special cases. And general OB-GYNs can, of course, use those providers to assist them in doing numerous studies that are needed, and not just necessarily for maternal fetal. The ones that we're looking for is nuchal translucency in the first trimester for ruling out genetic issues, and then genetic counseling if needed. Ultrasounds at 18 to 20 weeks for anatomic issues and evaluation in general in OB care. Scans for placental positioning to rule out placenta previas. Other biophysical profiles to assess growth, such as umbilical cord, vascular status, renal anomalies, anencephaly, or absence of part of the skull. Follow-up for growth retardation concerns is obviously part of the issue here in Georgia with premature deliveries and premature care. Amniotic fluid assessment, fetal presentation, and growth of fibroids that may be of concern for delivery as well can be done through telemedicine and ultrasound evaluation by the physicians. They can follow up with consults to describe concerns for care or needed referrals for extensive care if needed, and optimize the time for any further testing required. Patients may need to be made more aware of needed care and making sure correct medications are taken, testing is completed, and information regarding delivery needs are explained fully. Consults regarding birth control options obviously are available for gynecologic patients. I think that this definitely needs to be done, especially if you only have 50% of those counties having OB-GYNs. This in turn, with all the concern about abortion issues right now in the state, I think that birth control would be absolutely necessary and hopefully could be helped by telemedicine. Consultations for women with dysfunctional bleeding, amenorrhea, pelvic pain, dysmenorrhea, and ovulation can be done. Many of the women have polycystic ovarian syndrome with very few menses, hirsutism, and ovarian cysts that need ultrasounds to rule out cysts and endometrial hyperplasia. The precancerous lesions are definitely very important. It is a very high rate in the African American community, and many of the patients who are obese, which obviously I can speak about in just a second, tend to make that concern about endometrial hyperplasia and possible endometrial cancer a major issue, even in the young patients. They can have ultrasounds to have fibroids, ovarian endometriomas evaluated, and the concerns for pubertal age girls without periods or pubertal changes that need evaluation are something I know I'm very concerned about, because so many times they don't have a physician to go to and they wait until they're 18, 20 years old before getting fully evaluated for genetic problems or other issues that can be of concern. I'll just pause here. I don't have a slide about obesity, but I know working at Grady, that is one of the biggest issues we have and are very concerned about. I know just in the last couple of months, we've seen women who are only 32 years old who have had endometrial cancer stage 1 because their BMIs are like 50 or 60, and we have to refer them to possibly consider bariatric surgery just to be able to help them go beyond that, not even because most of the time they will not listen about the weight loss. We do send them to nutritionists, but that's another thing that perhaps telemedicine could help with nutritional care and try and get guidance about what to eat and what not to eat and how to lose weight. Patients can have ultrasounds, other testing is needed. If other extensive evaluation needs to be performed, referral to a nearby GYN can be done to obtain further care. Nurse practitioners or PAs may be able to do some testing and consults then to be scheduled. IUD placement ultrasounds can be done and reviewed. Further sonohistograms to evaluate fibroids, polyps, endometrial hyperplasia may need to be performed, and then consultations to follow up for care can be done. Additionally, need for menopausal symptoms and concerns is another large area that I know is not as difficult as obviously the issue for high-risk OB, but I think it's very important to consider. In patients with reproductive endocrinology and infertility, some of this obviously is perhaps beyond those in the rural areas, but still there are many patients who need to get to have consultations, not necessarily just for infertility, but obviously problems such as recurrent pregnancy loss, hyperprolactinemia, hypothyroidism. Consults can be done and lab work performed, and then follow up with an REI for further care through telemedicine. Regarding fibroids, endometriosis are very important. The big thing about polycystic ovarian syndrome, once again, is to make sure that these patients are trying to lose weight. You can place them on metformin, explain to them how to lose weight, taking medication that can be helpful, making sure we've done the sonohistograms or ultrasounds to see what their particular endometrial thickness is, which is obviously extremely important, and may have to be referred out in order to get an endometrial biopsy to make sure they don't have endometrial hyperplasia. And again, the other thing is that they need nutritional guidance, they need to see a dietitian, and to try and lose the weight. Many times patients come in and you have to have a BMI of 25 or less just to be able to achieve a pregnancy, and that's most of what a lot of our work is in the inner city, just trying to explain to people everything has to, you have to lose weight and we will put you on medications, but this is also important because if these patients do end up getting pregnant on their own, they are definitely at high risk, mainly for preeclampsia, hypertension. Type 2 diabetes definitely is a continuum of polycystic ovarian syndrome. Many of these patients develop type 2 diabetes and will have maternal problems with that and need to definitely be followed very carefully. So anyone who has PCOS, they definitely need, if they become pregnant, to be followed very closely. And of course, as we said, preeclampsia is, again, part of all the issues with maternal mortality, with any kind of problems, medical problems, cardiac issues that all have to be evaluated. And obviously, before anyone ever tries to get pregnant, you try and avoid that. You tell them they must be in great health and that we will not be doing anything unless you're totally evaluated and treated for all the different concerns we have to prevent any problems in the future. You can have a lot of patients who may have get older and do not may have run out of eggs early on, and we counsel them about that. So that's something that obviously is not in some populations, but it is available for those in remote areas that I know reproductive endocrinologists are few and far between, besides one or two in Savannah and mostly in the northern part in either Atlanta and or in Augusta. So we tend to be a little hard to find and get to. So this is, again, saves people time if they do have these diagnoses that need to be evaluated. Young girls with complicated primary amenorrhea, general amenorrhea, and pubertal issues have consultations to assess what needs to be ordered if their GYN has done their exams. Other concerns such as adrenal issues, hirsutism, menstrual irregularities, dysmenorrhea can also be discussed, and they need further sonihistograms to evaluate for anything like Asherman syndrome after multiple D&Cs, for miscarriages, hysterosalpingograms to see if they have tubal occlusion, for having had previous STDs, and for uterine abnormalities with any type of septate uterus or bicornuate uterus. Consultations regarding tubal occlusion from STDs need further counseling and discussion for fertility, but obviously that is much more complicated and very expensive. If complex issues regarding genetic abnormalities, the need for pre-implantation genetic diagnosis can obviously be discussed. This may not be in any of the populations we're talking about, but just to let anyone know that if there are such, that can easily be done. If they have a low ovarian reserve and need egg donation, we discuss that, along with egg freezing for anyone who happens to be in a remote area, perhaps even trying to help out in different parts of the region of Georgia, but would like to have their eggs frozen because they aren't married yet. That's an option for people. Gestational carriers, it can also be discussed for those who have the need for that in order to have a child. And the LGBTQ patients sometimes want to know about their options for achieving a pregnancy. So I think overall, they, concluding things are today's patients can feel comfortable consulting with their physicians using telemedicine for issues that don't require immediate exams or evaluation. And this is a time savings for many patients who can't take time off work in the middle of the day due to travel concerns or limitations. The labs and other testing can be done by the referring doctors. Allowing the patients the option for care is essential for those who otherwise would not receive it due to lack of specialized physicians or travel that is unavailable to them. It's a new frontier that will facilitate better care and communication for those patients who otherwise would not be amenable to standard office visits. Thank you, and I'll look forward to answering any questions at the end of this.
Gotten a host of interesting questions. Thank you both for a very lively discussion. So first question is actually for Dr. Leaf. For patients who are regularly treated for telemedicine, how often would you like to see them, and what is a determining factor based on the most common illnesses that you may treat patients for?
Well, I think mostly polycystic ovarian syndrome would be one that you need follow-up for. After you do the consults, get the labs, get all the testing, then you have another consult to make sure you have it all correct. And then you refer them out either for nutritional help, give them medications that could be, called in or ordered. And then they would need to be followed up about every 3 months, just to make sure they're doing well, have no problems, etc. For other things, it might be more intensive depending on what the issue is that they're dealing with. But most of the time, it's just getting the correct labs, getting all the information for the patient, and then having another consult and saying, you need to do this, this, and this, and then follow up from there, depending on what it is that we're discussing.
Measures of numbers of prenatal visits. And how does this affect billing? How does telemedicine affect billing?
So am I live? Okay, so I'll answer that question to start with. There are variations state to state, but in general, for telemedicine to be reimbursable, it needs to be the exact same quality as in person. So we have to, telephonic is not reimbursable. It is not the same experience as we're having right now, even interactively. So there are requirements to meet as far as telemedicine. You bring up a very good point in terms of quality. It is still what I would say evolutionary. A good example of this is Joint Commission or CQHI or whatever. Standards are still being developed. Joint Commission started down the telehealth trail of creating standards, and I would say overall not many telehealth entities are credentialed, and the credentialing standards are not clear. But what is crystal clear is to be reimbursable and to have the best outcome. We have to be able to have the tools peripherally, the AV connectivity, image transfer, whatever it is that we would have done in person, we still have to be able to do telephonically to be a viable, quality telehealth encounter.
Great. Okay, next question is, this question can go to either of you. What are the differences in accessing care that you see within the urban community when compared to the rural community?
Obviously, just as a note, if you have to have an ultrasound or any type of more advanced studies, you definitely have to have all of it correct and available so that it can be performed while the doctor's there or needs to evaluate it. Mostly it's for the maternal fetal medicine physician because that has to be done
So I'd
right
like to
there
add on,
and
I agree
then.
with Dr.
For
Mitchell
somebody like me
totally.
who
One
needs
thing
a
I would add, as we have gone
hysterosalpingogram, I
into
can
a
be sent that
variety of
result and
settings
see
between
it
urban and
and
rural,
consult about it,
we
but I
can
don't
wire
need to
up
be
tech
physically
pretty
there
much
to see it
anywhere,
and do it.
but it is the workers on the ground that we call clinical presenters with the patient that are the problem, because I can buy an ultrasound machine, I can hook up telemedicine, but if I don't have an ultrasonographer that can get me that twin-to-twin transfusion picture, it's all for naught. So the doctors are ready and able wherever they sit. One great thing about telemedicine, we have doctors in Chicago, we have doctors in Georgia, we have doctors in Kentucky, they're all over, but they are still dependent upon the skill set and the training of the telehealth presenter that is with the patient. And I think in telemedicine, a trend I'm seeing is remote patient monitoring from the home. So it's a little bit different. So we still require for high-risk obstetrics that the patient presents to a clinical setting for that very reason. And I think a lot of people get so caught up in the technology of it, they forget that the doctor on the camera is going to say, well, now I need a lab, who's going to draw that? Now I need a referral to, who's going to facilitate that? So in rural areas, we find just much more healthcare workforce that is more clinically available and trained than we often do in a more remote rural area in terms of ultrasound and nurses and clinical staff that can do the telehealth presenting part. That's been one of our biggest challenges.
Makes sense. It makes sense. And I could speak to it from the Morehouse telehealth program. We have been venturing into the space of remote monitoring, but that's been primarily for diabetes and hypertensive care. But in this space, again, I definitely think there would be opportunities for using it. We just have to explore the benefits in the technology and how it would work in this space. Another question, I think that can go to both of you. How do you address client complaints, and what are the most common complaints in this space?
I'll go first. So we have a patient satisfaction program here, and we've actually presented on it nationally in the telemedicine community, and it is quite interesting.
I don't have answers
in
to
general,
that,
I'll let you know what we do. We do our patient satisfaction through email connectivity immediately after their first telehealth encounter, and again after their second telehealth encounter, if there is one, to see if we have consistency. The compliance rate and that is mostly because a lot of people in rural areas don't have a phone, don't have connectivity even. So the return is probably better than in some areas. We've had as high as a 40% return, which is quite high for an email response. And in general, our patients are very happy with the telehealth encounter. What are common complaints? They're things you won't expect. Our very first, as we were learners, complaint is I can't hear well. So we would look and see we see people leaning toward the camera like I'm doing. It's the teeniest things, and we facilitate that by changing out the speakers or adding an external speaker. I would say the number one thing we've done to improve satisfaction is to train the patient prior to the AV call about what to expect. So I'll never forget the very first telemedicine call we ever did. I was able to be an observer, and the patient's eyes were like deers in the headlights, and she says, "Can the doctor hear me?" Which, of course, we were on an interactive call. We could hear everything, but we did not do our best work in telling them what to expect. So I think when we educate the patient, they are required with us to sign a consent ahead of time, that they know it's going to be a telehealth encounter. The more that we manage the expectations and train them about this is how it's alike, the doctor can see and hear you. You're going to be with a clinical person that will follow up on the care, and this is how we get fewer and fewer and fewer complaints. That's the number one thing. Second biggest complaint is wait time, and it is a huge issue in telemedicine because the doctors sitting and waiting to connect are blind until they click on the camera as to what's going on in the clinical site. So there is a whole lot of interruption of clinical workflow. In other words, I guess I'm saying if you're working in a brick and mortar clinical facility and then you've got a work-in telemedicine patient, you might be hung up. It might take you 15 minutes or 20 minutes and the patient's sitting there in the exam room somewhere waiting for the camera to come on to talk to their doctor. So how do we manage virtual clinical flow when the providers are distant and cannot always see what's happening? So I'd say our second largest complaint is probably wait time. And it's compounded in my specialty because when I get referred a high-risk patient, we do not know until we see the ultrasound what is truly happening. They can be referred for a birth defect, and that is not the problem. And now we have a fetal demise, and everything broke down, and people across states are now waiting for their time with the doctor. So I think that virtual clinical flow management is a challenge that we're all doing our best to improve with telehealth. But those are the two complaints I hear the most.
I don't have anything about a complaint, but I know patients like it if I say, I can talk to you after 4 o'clock or 5 o'clock. And that's really been helpful because many of the couples can't get off.
I would agree with Dr. Mitchell-Leaf, but I would also add the caveat that we also have had extended hours, which for us often in a clinical setting is not the same as
big positive
Dr.
thing
Mitchell
for them
doing
that
a
works,
consult only.
and they didn't have to take
However,
work to
the
do so.
learning lesson for us is BYOD. So if the patient is in their home on a laptop or a smartphone or iPad, all of the platforms do not equally translate to the same experience. Most apps have been made for iPhones in our experience. So it has been a challenge to when the patient is on their end having an AV call, sometimes the platform doesn't reach all the way through to the patient. So that's just another thing to check in advance to manage an expectation.
I will add, for us at Morehouse, we've done two things actually, and both of them were lessons learned, partially probably from talking to you, Tanya, and just from our experiences in doing it. One was we began creating blocks of time so that the provider wasn't going in and out, in and out, in and out to see in-person patients and then virtual patients, in-person patients and then in virtual patients, but really just creating a block. So trying to cluster all of the patients together. And then, doing those tests are critical. If we, as long as we were able to do the test and it worked the day of, we usually felt comfortable that it would actually work for the appointment. But then the next thing we started doing is working with interns who can at least launch the appointment. So when a doctor is coming into the appointment, everything is up and ready to go for the
Yeah.
doc.
I know I had a visit yesterday afternoon with the president of one of the big EMR companies, and we were talking about remote home monitoring, and we use it as a backup through our EMR because in my world, you have lots of different kinds of clients, hospitals, government clinics, each have their own hardware, their own network, their own access. And we're now talking about when we verify the telehealth appointment on the patient end, if they're going to be doing a device, we attach an instruction sheet. Like start 10 minutes early, set your phone for this, make sure your audio's on. And so if it comes in with the appointment time, it kind of gives them a little time to set up. For our platforms, we pretty much have a window that we can preset that if it is a remote home monitoring or that kind of situation, they have a window of about 20 minutes to an hour, and we can control that what that window is. But you bring up a good point with the block scheduling. I know you and I have talked about that. For new clients, for us as well, we have emergency slots because we need them in our specialty for transport or delivery or critical care situations. But 90% of our visits are scheduled in a block. So the doctors and the providers can better schedule the patients and the wait time is minimized.
Gotcha. This next question is from Vicki Berklin, who's one of the participants in today's webinar. Do your MFM providers do live ultrasound reads? And if so, what is the technology framework that they use?
Yes, great question. I'll take that, Dorothy. So we do have live scanning capability at every one of our sites. It is the most challenging piece of the connectivity that we have. So we walk into a lot of facilities and they say we have a PACS system already, we're going to use that. And I say, okay, great, but in telehealth, I need to know what's happening in the moment. And I might, for reasons we've already talked about, like education and limitations in the rural side of the house where there's not quality perinatal scanners, we revert to live scanning for certain clinical situations, obesity being one. It is very difficult to image on an extreme obese patient, so the doctors want to direct the ultrasonographer's hands. Extreme fetal anomalies where we want to get a really good look, the doctor might want to direct the hands of the tech. It is done probably in less than 10% of our overall image capture. Mostly we do a store and forward where we take a picture, we transmit it. Within 5 minutes, the doctor has all the images. But for live scanning, we do that. Technology-wise, without going into too much detail, there are certain configurations, but if you think of it, and again, my clients often determine what the configuration will be, not me. So we work in all kinds of situations, but some criteria that is a must-have is your ultrasound machine must be DICOM reporting capable to transmit the study data plus the real-time image. It's connected then to what I would call some kind of widget that is basically a fast video frame grabber and then transmitted along whatever the network pipeline is. But if you have old ultrasound technology, in general, a good breakpoint is if it's 3 years or newer, you're probably fine and it's built in. If it's over 3 years, it's iffy. And if you're wondering, we typically do site reviews. We take a picture of your serial number on the back of your ultrasound machine, send it to the manufacturer and ask if it is DICOM reporting capable. And it's really the output cable that goes then into the frame grabber. That's the technology that we use. And there's lots of different people that fulfill that. We don't use carts anymore. So a lot of people think you must have a telemedicine cart. We have not placed we use them because the hospitals have them already, but we have not placed a new site with a telemedicine cart in probably 4 years. So we do live scan less than 10% of the time. It starts with the ultrasound capability as the beginning point, and then the configuration would depend upon legacy equipment, but very easy to do, not that complicated.
So Tanya, can you give me a breakdown between your synchronous and asynchronous appointments? How many are you doing any
We rarely do store, and we only have one client, actually, a government client. No surprise there. No offense to anybody out there, where they actually is a little bit larger of a gap from when we have an asynchronous where we take a picture and then the doctor will see it later and then reconnect with the patient later. We do what I would say is more of a hybrid visit. So again, we're going to have the patient in the ultrasound room. We're going to take all the pictures required for that study, and we're immediately going to upload them. Then in clinics which are large volume for block scheduling, we will move that patient to a consult room, and while the patient's being moved, the next patient comes in ultrasound, and then the doctor on the remote end is viewing the images. So in one hand, it's synchronous in that it's at the time of the visit, right? So the patient doesn't come back and they don't reconnect with the doctor later, but there's about a five-minute gap for uploading and picture review. To be asynchronous would be if the patient's in a remote area, the tech is only available on a certain day, the patient gets their pictures taken one day, and then the doctor would connect with them on another platform at another time. So obviously that would be non-urgent patients. We might be seeing them once a month for growth or fetal anomaly over a pregnancy period and comparing, one over the other. But in terms of a percent, I'd say less than 5% are asynchronous, 95% are at the time of the visit.
Thank you. Last couple of questions. This next question is for Dr. Leaf. What are how can telemedicine be used to get people access to care early? And what are the areas of need where people would need to get access to care early?
Well, beside OB, which I think Tanya already spoke about, if you have patients that mostly I take care of, such as recurrent pregnancy loss or, pubertal issues that maybe really need to be done by age 13 or 16, you need to be able to have individuals be seen early on and sent by their doctor saying, here's what I'm finding, this is what I need, can we have a consult for this patient? And I think it's really up to the doctors that maybe, or even family members, if they have a doctor and say, hey, this is a problem, can we talk to somebody? I can't get all the way to Atlanta, but I can come, could talk to her. Then these are the kind of telemedicine patients that would really do well. And anything that's of concern that nobody can take care of.
I just would like to add one thing.
Telemedicine can be a quick discussion and make it so that it just doesn't keep going on and on for any problem that may be bothering the patient.
Even if it's not known in this pregnancy, probably a good reason for early intervention to at least rule it out before we really have a problem while we're still in that little antepartum first trimester window.
So you guys become president for a day. In your dream world,
and diabetes, gestational diabetes, preeclampsia, anything else like that.
So my wish list would be reimbursement, because you're not going to get providers.
I think Tanya has talked about that. So and all
when we started,
concerns
we only had
about
8
the regulations
states out of 50 whose Medicaid program even covered it. And on top of, if it's covered, there was not parity law that made them pay. Saying it's covered and getting your money are totally different things. We are still way behind in parity law. So since telemedicine has been in the US and globally for almost 30 plus years, it's been proven as a tool that's effective in many cases. I don't know why adoption is still very slow compared to the need out there. So if I were president for a day, I would mandate Medicaid expansion and parity coverage across the United States. Yes. Well, and especially in this specialty, 50% are rural births. So those are generally higher Medicaid populations.
for quicker care and better care
Okay, guys,
for those who
we've come
don't
to
get
the
any.
end of our questions.
Yes.
What I would like to do, we could start with Tanya and end with Dr. Leaf, but if you guys can just provide a 1 or 2 minute closing statement, key takeaways you would want the audience to lead this discussion with.
I'll just start, just mine is fast. I think any time that you have a patient that needs assistance, mostly OB, of course, but in any kind of gynecology or reproductive endocrine issues, it is better to be able to say, can I have a consult for this patient, rather than sitting there hoping it gets better, and get some answers and know what tests to do and when to do it and to get it
I would
on, and
address
so that the
mine
patient
to
doesn't have
telehealth
to
adoption.
suffer and
So if
or
you do not
wait
have
so
telehealth
long
in your
to know
facility or it's
answers
not
that they might
widespread,
need
I'm
to
still
move on and
astounded
get
by
treated for.
large hospital systems I walk into that have no telehealth presence, no telehealth expertise, but it is not that complicated. The biggest myth is how complicated it is. It has changed so much. It's just like any medical. Every 6 months, the technology changes. It's cheaper. It's easier. There's better apps. The movement has been so much. So I would say, please help us spread technology by wherever you are, whoever you are. Get educated yourself. And if you're not comfortable, there's a myriad of people available to help you in every state. So make some calls. And one resource I would like to leave everybody with in telehealth is HRSA and the feds have divided the United States into 12 federal resource centers. And they're multi-states in each resource center. And these centers have reimbursement, knowledge, policies written already, experts that can help you connect, preferred vendor lists, and you can easily find them online, and they're available and they're free to get their expertise. So start learning, help us spread adoption at a faster pace, at least start somewhere. That's what I would say.
Thank you both so much. Really, really informative discussion. Really want to thank Dr. Mitchell Leaf, who is specializing in infertility for the MHC telehealth program, and Dr. Tanya Mack, who's obviously world-renowned with all of her telehealth work and 30,000 and counting visits. That's a very remarkable space to be, and I appreciate you both bringing your years of insight into enhancing this discussion. I also want to thank all the attendees for your participation, your questions. We will be archiving this webinar, so you'll have access to this webinar. Again, thank you all for your participation, and have a great day.
Thank you.
You're very welcome.